I think that's us live now.
Hello. All right. Hi, everyone. Thanks for joining us today. Um, so we have the next talk in our series, which is gastroenterology. Sorry, I think there's a bit of an echo, Nandini.
From me,
Possibly. I'm not sure. I don't know who that's coming from. But anyway, sorry,
I,
ignore me
I
for
can't
a
hear an
second.
echo.
Fine. So sorry. Go back to what I was saying. So yeah, welcome to the talk. So today we're discussing gastroenterology. There's a lot of different conditions that you do need to know for this because it incorporates the surgical side and the medical side of things. So we've tried to condense it down to the most high yield areas. And there's just a couple of big topics that we've omitted just because they are covered quite extensively. Um, so let me just quickly share my slides and then we can get started with things. There we go. All right. So just to quickly introduce ourselves, so hopefully you've been to some of the previous sessions. So I'm Mehmet, part of the committee for MedTech. So we're doing a final series and various other series as well coming up, like F1 prep, preparing for SFP interviews as well. And
I'm Nandini. I'm also an FY1, also on the MedTech committee.
perfect. So these are just some of the conditions that we'll cover at some point today, but we'll share the slides on Medal later so you can have a closer look. All right, so I think we'll go straight into it. So we've changed the format a little bit. So we'll go question and then answer, question and then answer, rather than doing all the questions at once, answers later down the line. So once everyone's ready, if you have a pen and paper, you have a minute for every question. So we'll get started now.
Okay, so that's been about a minute. Then to go to the answer. So question one, a 55-year-old female patient presents to A&E with nausea, vomiting, and a 3-day history of constipation. She normally opens her bowels every day. On examination, she has generalized tenderness and rigidity of her abdomen and no audible bowel sounds. So what's the most appropriate management plan? And the right answer is B, which is an urgent laparotomy. So in this question, the patient's presenting with symptoms that indicate she has bowel obstruction, but the generalized tenderness and rigidity of her abdomen indicate that she's got peritonitis and potentially a perforated bowel. And so that's why urgent laparotomy is the correct answer over like drip and suck. So your more conservative management for a bowel obstruction, or an urgent colonoscopy, and any of the other answers. Next slide, please. Thanks. So just to go over bowel obstruction, there are two different types. So there's mechanical bowel obstruction, which is what you tend to do operative management on in surgery. So you've got tumours, adhesions, anything that's physically blocking the movement of food through the GI tract. And then you've also got your functional obstruction, also known as ileus. So there's not a physical obstruction there, but for whatever reason, the bowels aren't actually moving food through the GI tract. So could be post-op ileus, could potentially be drug-induced. So with your opiates, they can lead to constipation. Could be secondary to diverticulitis, could happen with autonomic neuropathy, etc. So some of the causes of small bowel obstruction are adhesions. That's the most common cause. So in a stem in a question, it may hint to the patient having adhesions if they've had previous surgery on their abdomen. It may also be secondary to cecal volvulus or a gallstone ileus. And then causes of large bowel obstruction, generally tumours, could be diverticular disease, and it could be sigmoid volvulus. Patients generally present with central abdominal pain as well as abdominal distension. They oftentimes have vomiting, and this would be feculent vomiting, as well as absolute constipation. So they're not opening their bowels at all, even to pass gas. On examination, it may be a tender abdomen, but it is generally still soft. And on auscultation, you tend to hear either no bowel sounds or tinkling bowel sounds. So for your investigations, obviously you'd want to do your routine bloods. You also want to get a lactate to check for any sort of bowel ischemia, as well as a VBG to make sure that they're not becoming acidotic. If you're suspecting that they may have a volvulus, you'd want to do an abdominal x-ray, but just for general clinical practice, at least in my hospital, they are quite fussy about abdo x-rays. So that's something you might want to keep in mind. But for exam purposes, abdo x-ray. For a small bowel obstruction, you'll see that the bowel loops are dilated more than 3 centimeters. You'll see what's called valvulae conniventes, which are lines all across the small bowel, which you wouldn't generally see on someone who's got a normal abdomen and an abdo x-ray, but it's because it's dilated that you can actually see those lines. And if the patient has cecal volvulus, you may see what's called the embryo sign. So if we just go back a slide, it's this second picture where if you have a slightly creative imagination, you can think of it as looking like an embryo. It's almost got 3 parts to it, and that's the sign for cecal volvulus. And then if we could go forward a slide. In an abdo x-ray for someone with a large bowel obstruction, you'll see that the bowel is dilated more than 6 centimeters, and at the cecum, it can be more than 9 centimeters. You'll see the hostra are visible. So these are small lines you'll see across the bowel that don't go completely across. And if it's a sigmoid volvulus, you may see what's known as the coffee bean sign on an abdo x-ray. So if you go back a slide again, this first picture looks like a coffee bean. It's got that split in the middle, and then the 2 really large dilated loops of bowel. And I think you can also see the hostra on there as well. If you go forward a slide, thank you. And then you may also want to do a CT abdo-pelvis with contrast, because that'll give you a much more detailed picture of the abdomen as a whole. So for your management, initially, you want to do the drip and suck. So inserting a large bore NG, let that drain out any vomit or any substances that are in the bowel, give them IV fluids and keep them nil by mouth, and that's your conservative management. If a patient has sigmoid volvulus, you want to take them for sigmoidoscopy and then decompress with a flatus tube. I think I forgot to write tube there at the end, but you'd still want to do your drip and suck technique initially. And then you'd want to take the patient for surgery if drip and suck isn't helping to resolve their obstruction, or if the patient has cecal volvulus. So for a perforation, some of the risk factors are a patient who has a bowel obstruction, patients with diverticular disease, and patients with malignancy. So you always want to have in the back of your mind, has this patient perforated if you're managing someone with small bowel or large bowel obstruction? For the presentation, they'll have really severe abdominal pain and tenderness. Their abdomen will be really rigid. They'll often be lying on their bed, just not moving at all because they're in so much pain. And the patient will have absent bowel sounds. For the investigations, you really want to make sure you're getting a lactate and a VBG because they may have bowel ischemia. You also want to do a group and save because these patients will most likely be taken to theatre if they're fit for operation. You'd also want to get an erect chest x-ray done immediately because then you'd be looking for free air under the diaphragm. And that's a classic sign that the patient has perforated. And then management would be urgent referral to general surgery, who will take them for a laparotomy. Okay, so now question 2, I'll give you a minute for this. Okay. So for question 2, a 67-year-old man is under investigation by the upper GI surgery team for dysphagia to solid foods, which has worsened over the past few months. He's now only able to eat soft foods like porridge and yogurt. He's also lost 3 stone in weight over the past 2 months. What is the most likely finding in this patient's barium swallow? So the right answer is A, an apple core stricture. So just to quickly go over the other answers, a bird beak appearance is generally seen in achalasia. Outpouching on the posterior wall junction between the esophagus and the pharynx is a pharyngeal pouch. Patients it's unlikely they'll have a normal barium swallow if they've gotten to the point where they can only eat soft foods and they've also lost weight. And patients with a corkscrew esophagus generally have diffuse esophageal spasms. And so the diagnosis here from this apple core stricturing that's seen on barium swallow is esophageal cancer. So here are kind of your top differentials for an upper GI cause of dysphagia. So for esophageal cancer, you generally get progressive dysphagia to solids. It doesn't generally progress to liquids unless it's really advanced. It's typically a short history, so over weeks to months. And as an additional symptom, you may also get patients presenting with a hoarse voice if the tumour is compressing on the recurrent laryngeal nerve. And you'll see an apple core sign on a barium swallow, which is kind of the narrowing of the esophagus due to the tumour compressing. And then for achalasia, you get dysphagia to solids and liquids from the very beginning. So that's different to that kind of progressive picture you see in esophageal cancer. Patients tend to present with sporadic episodes that respond spontaneously. And then you also get a bird beak appearance on barium swallow. So you get like an expanded esophagus, and then it suddenly kind of tapers off. And if anyone doesn't know, achalasia is what happens when you kind of get, it's like loss of the innervation to the lower esophageal sphincter by the myenteric plexus. In diffuse esophageal spasm, you get intermittent dysphagia and heartburn, and you'll see what's called a nutcracker esophagus on on a barium swallow, or corkscrew esophagus. And in a pharyngeal pouch, patients can present with dysphagia, and they also present with regurgitation quite classically. So they may tell you that a few hours after they've eaten, they're noticing they're bringing up like whole bits of foods, like patient had carrots in their dinner and like, oh, I regurgitated a bit of carrot into my mouth. You may also see a neck swelling. They may also have halitosis, because obviously that food is just kind of sitting in the pharyngeal pouch. And you would see it on a barium swallow. And I know that a barium swallow is a fairly outdated investigation currently, but it's still quite an exam favourite, just in terms of those like classic signs. Okay, so another minute for question 3. Okay, so question 3. A 40-year-old patient presents with coffee ground vomit and melena. On examination, their blood pressure is 70/50, heart rate is 124, and they also have asterixis. They undergo an endoscopy, which successfully stops the bleeding. Which medication should they be discharged with to prevent another upper GI bleed? And so the correct answer is A, which is propranolol. And so the STEM is trying to get at the fact that this patient has esophageal varices. The asterixis is the hint that the patient has liver disease and presenting with such kind of being so systemically unwell from an upper GI bleed as well. Next slide, please. So causes of an upper GI bleed, it can be caused by varices, that could be esophageal varices, it could be gastric varices, can be caused by ulcers, can be caused by a bleeding tumour, and could also be caused by a Mallory-Weiss tear, which is when patients get a small tear in their esophagus because they're vomiting so much. So in order to risk stratify patients who have presented with an upper GI bleed, you can do the Glasgow-Blatchford score, and this is trying to identify patients who might be candidates for outpatient management of their upper GI bleed. You can also do the Rockall score, which is trying to identify patients at risk for adverse outcomes as a result of their upper GI bleed. Patients present with hematemesis, so this can be fresh red blood or potentially coffee ground vomit, which is blood that's been digested. And they can also present with melena, which is that black tar-like stool, again, which is from blood that has been digested. So some of the investigations you'd want to do a full blood count, you want to pay attention to their hemoglobin, see if that's dropping. You'd want to look at their Us-and-Es. Patients with an upper GI bleed have a raised urea because, again, that's from the breakdown of the red blood cells. You may also want to just do routine bloods like a CRP, and you want to check their LFTs as well, as if the patient doesn't have known liver disease or known varices, this could potentially point you in the right direction as to the cause. And you may also want to do a group and save on these patients because you don't know how severe their bleeding is going to be. So generally, if the patient has varices, you want to give them IV terlipressin and antibiotics immediately, as well, along with any sort of fluid resus and doing your ATE assessment. If they have known varices, you also want to take them for an OGD. And generally, you take anybody for an OGD once you've actually controlled the bleeding so they can actually find out the source. If it's a non-variceal bleeding, where you don't actually know if the patient has varices, you'd want to give PPIs. When you're in endoscopy, you can control variceal bleeding by doing band ligation of the varices. You can give N-butyl-2 cyanoacrylate, which is a very long, fancy name for something you can inject into the varices to help stop them bleeding. You can do TIPS, which is a trans-intrahepatic portosystemic shunt, which you can see on the diagram. It just sort of diverts the blood flow from the portal vein to the branch of the hepatic vein. And that's if your band ligation and sclerotherapy doesn't work in endoscopy. And then you can also insert a Sengsten-Blakemore tube if the patient's having an uncontrolled hemorrhage, so nothing else is working. That's essentially a tube that goes down the nose into the stomach, and it's like a balloon that inflates. So essentially just trying to compress the source of the bleeding to stop it. If all else fails, you would want to take them for surgery. So if they've had a failed endoscopic management of their bleeding. So for prophylaxis for variceal bleeds, you can give propranolol, but this is only in the case of like known varices. Okay, so another minute for question 4. Okay, so question 4. A 30-year-old woman returns to a clinic after receiving hepatitis B serology test. Her results are as follows. So Hep B surface antigen is positive, antibodies to the surface antigen are negative, and HBe antigen is positive, anti-hepatitis HBC IgM, which is antibodies to the hepatitis B core antigen, are negative in terms of the IgM, but positive for the IgG. So what's her hepatitis B status? So this shows that she's an active chronic hepatitis B carrier. So she's got an infection, which is chronic. So for the next slide, this chart quite nicely goes over hepatitis B serology, which is something that I found quite difficult in medical school. So your surface antigen denotes if the patient has a current hepatitis B infection, and this includes acute or chronic. Your core antigens are a marker of some level of hepatitis B infection. So IgM represents an acute infection, and then IgG represents a chronic infection. Antibodies to your surface antigen indicate that the patient has some level of immunity, whether this is from vaccination or from a previous infection. Your hepatitis B E antigen is a marker of infectivity and activity of disease. And so anti-HBe antigen is detected in people who are chronically infected or patients who have actually cleared an infection. So if we just kind of go back to the question, just to go over some of the answers. So this patient has a positive surface antigen, so she's got an infection at the moment. Negative anti-HBs, so she's not cleared the infection and she's not been vaccinated. Her HBe is positive, so this is an active infection that she could pass on to somebody else. Her IgM is negative, indicating that it's not likely to be an acute infection, and her IgG is positive, so that's likely to be an active chronic infection. For an acute hepatitis B infection, you'd likely see positive surface antigen. You may have a positive HBe, and you'd have a positive IgM. If the patient is a hepatitis B carrier with no active infection, you would have hepatitis B antigen is positive, but and maybe the surface antigen would be positive as well, but not a positive IgG. Immunity following vaccination will have everything being negative apart from the anti-HBs. And then immunity following an infection you'll have a positive core antigen, negative surface antigen, with a positive anti-HBs. Okay, I hope that covers that. And if anyone has any questions, feel free to pop them in the chat or just kind of interrupt the session. So next question. Okay, so question 5. A 50-year-old woman presents with abdominal distension on a background of chronic alcohol excess. On examination, her abdomen is soft and non-tender, it's dull to percuss and has a positive fluid thrill. She has an acidic tap done, which shows the following results. So she's got 40 red blood cells per microliter, 170 white cells per microliter, 2 neutrophils per microliter, protein is 3, LDH is 195, and her serum albumin is 30. So the most appropriate management plan for this patient is spironolactone and a sodium-restricted diet. And that is because, so this patient, from these results, their white cell count is less than 225 or 250 off the top of my head. I can't remember which one, but that's what indicates spontaneous bacterial peritonitis or some level of infection. If your neutrophils are high, that indicates it's SBP. If your leukocytes are high, it could be TB ascites, but I think that's quite advanced, so I'd just forget about that. And because she doesn't have an active infection, she just needs diuretics to actually get rid of the fluid, as well as a sodium-restricted diet to prevent it from coming back. So IV cefotaxime is what you would give for active SBP. A large volume paracentesis would be for tense ascites, but her abdomen is soft. There's no indication that she actually has tense ascites, so it's better to just go with your medical management for trying to get rid of it. She does have a need for acute intervention, as you don't want the ascites to sit there and for it to then go on to develop SBP. And then oral Cipro is your prophylaxis for patients who may develop SBP. So just to go over ascites, so as with any sort of effusion, it could be transudative or it could be exudative. If your serum albumin ascites gradient is more than 11, so this is taking your serum albumin level and then minusing your ascites albumin level from it. If you get 11, more than 11, it's likely transudative, so due to portal hypertension, that could be due to liver cirrhosis, it could be due to heart failure. And then ascites that's exudative, so a serum albumin ascites gradient of less than 11, could be due to nephrotic syndrome or it could be due to malignancy. So it generally presents with abdominal distension, and in some patients it's really obvious, like they look like they're pregnant. It'll be dull on percussion, it'll have a positive fluid thrill and a positive shifting dullness. For your investigations, you may want to do an abdo ultrasound scan, but your definitive investigation is going to be an acidic tap. Abdo ultrasound scans are helpful because you can see, is the liver cirrhotic? And then in practice, you can ask the ultrasonographers just in the request, like to mark the area where there's the most ascites so you know where to go for your acidic tap. Next slide, please. So for your acidic tap interpretation, as we said before, your serum albumin ascites gradient will tell you whether it's transudative or exudative, as well as your LDH. So if it's less than 225, it's likely transudative. If it's more than 225, it's likely exudative. That's because LDH can be a marker of like inflammation in the body. So more inflammation, more likely it is to actually be exudative. And if you've got a high protein, so more than 4 grams per deciliter, that indicates that there's some level of infection there. So whether that's SBP, whether that's TB. And you also want to have a look at your white cells. So if it's less than 250, there's no active infection. If it's more than 250, that's abnormal, indicates that there is an infection. If there's a neutrophil predominance, it's likely SBP. And if it's lymphocyte predominant, it's likely TB. So looking at that patient, LDH was less than 225. Serum albumin ascites gradient would have been more than 11. Protein was less than 4. White cells were less than 250. So all of that indicates that it's a transudative ascites without an infection. So for management, you want to get daily weights on the patient to see are they actually offloading this fluid. Again, you want to do a fluid balance chart. Ideally, patient would be in a negative fluid balance. And you want to sodium restrict the patient. Spironolactone is your first-line diuretic for ascites, and if you're finding they're not actually losing weight, you can add in furosemide. If the patient has spontaneous bacterial peritonitis, you want to give IV cefataxime. And the criteria for giving patients oral Cipro for prophylaxis is if they've got cirrhosis and if the protein levels are less than 15 on the acidic tap. And then, as I said before, you would only do a large volume paracentesis if there's tense ascites, which is something you'd find on examination. And then just to go over decompensated liver disease. So this can present with a number of different conditions. So it could be jaundice, and you'd typically see a mix of conjugated and unconjugated bilirubin. And you'd also see a hepatic picture of cholestasis. So your AST and your ALT and your transaminases will be raised more than any raise in ALP. So decompensated liver disease can present with ascites or SBP. You can also get patients presenting with hepatic encephalopathy, so confusion. And to manage this, you want to make sure that patients are on lactulose. That's first line, and if that isn't helping to resolve their hepatic encephalopathy, you'd want to give rifaximin as well. And these will help to kind of limit the amount of ammonia that's in the body, which is thought to be the cause of their encephalopathy. And if patients are encephalopathic, they can often have asterixis, so kind of that flapping tremor. Patients can also present with renal impairment. They may have hepatorenal syndrome. They may have GI bleeding from varices, and they may also become septic. So question 6. Just give you another minute for that. Okay, and just before we go on to question 6, just for when you're actually on the wards, if you think a patient has decompensated liver cirrhosis, you can find the Basel bundle online if you just Google it, and that's a really helpful tool just to kind of walk you through looking for different signs and how to manage them. But on to question 6. So you've got a 37-year-old man who presents to A&E with a 2-day history of persistent right upper quadrant pain and nausea. He has previously experienced similar pains, but this is resolved spontaneously. On examination, his temperature is 38 degrees, his pulse is 90 beats per minute, and he's got a positive Murphy's sign. Which investigation is first line for this patient? So the correct answer is C, which is an abdo ultrasound scan, and the patient is presenting with signs of acute cholecystitis. And an abdo ultrasound is the most sensitive for actually having a look at the biliary tree, seeing whether you've got like an inflamed, thick-walled gallbladder, and seeing if there are any stones either in the gallbladder itself or in the common bile duct. So for right upper quadrant pain, it's helpful to just kind of think of how like gallstones, acute cholecystitis, and ascending cholangitis can be differentiated. So gallstones will present with right upper quadrant pain that typically resolves spontaneously. Acute cholecystitis is the same right upper quadrant pain, but patients often have fevers. And then ascending cholangitis has fever, right upper quadrant pain, and jaundice, and that's Charcot's triad. So an abdo ultrasound scan is going to be your first line investigation. If you're not 100% sure whether this, or you think there may be other abdominal pathologies, you may want to do a CT abdo-pelvis just to help rule that out. And if you see gallstones on the abdo ultrasound scan and the patient's got cholecystitis or cholangitis, you may want to do an MRCP, as this is more sensitive for having a look at the biliary tree. In order to manage gallstones, it's typically an outpatient elective laparoscopic cholecystectomy. acute cholecystitis is managed with IV antibiotics, and you would ideally get the patient a lap chole within 1 week of presentation. And then for ascending cholangitis, you'd want to give IV antibiotics again and a lap chole, but not necessarily within a week. You'd want to make sure the patient's not septic first. Okay, question 7. Okay, question 7. So a 40-year-old man presents to his GP with recurrent episodes of heartburn and epigastric pain after eating. He is systemically well. He's not on any prescription or over-the-counter medications at present. So what's the most appropriate management plan? For this man, the presentation is indicative of some sort of peptic ulcer, and a really common cause of peptic ulcers is H. pylori. So you'd want to do a urea breath test to actually confirm whether or not the patient does have an H. pylori infection. You don't want to just give empirical treatment. It's better to actually know and actually do the diagnostic test. So that's why answer C, is the right answer. I don't think we're at the point of referring for an OGD just yet. We've not actually done any sort of trial of medical management. And the patient doesn't necessarily need lifestyle counselling at this point in time for his presentation of peptic ulcer disease. If a patient was presenting with, and they've been taking multiple courses of NSAIDs, you may want to counsel them on the fact that these are GI irritants, but this patient isn't actually on any medications at present. So for peptic ulcers, you can separate your causes into A, B, and C. So A could be alcohol. It could be an autoimmune condition that's causing their peptic ulcers. It could be B, which is a bacterial infection, which is H. pylori. It could be C, which is chemicals or medications. So common medication causes of ulcers are NSAIDs, bisphosphonates, and steroids. Patients typically present with epigastric pain. If it's caused or triggered by eating, it indicates that it's a gastric ulcer, whereas if it's relieved by eating, it's much more likely to be a duodenal ulcer. So for your investigations, you can do a urea breath test for H. pylori, you can do a stool antigen test for H. pylori, and if you've already tried the patient on PPIs and H2 antagonists, you may want to refer for an OGD, or you may want to refer for an OGD outright if the patient's got any sort of red flag symptoms. So if they lost weight recently, anything else that could indicate this patient has a more sinister underlying condition. So for your management, if your H. pylori tests are positive, you want to give 2 antibiotics and a PPI. So typically this is amoxicillin, clarithromycin, and omeprazole. But if the patient's pen allergic, you can give metronidazole, clarithromycin, and omeprazole, but some sort of PPI and 2 antibiotics. If the patient doesn't have a positive H. pylori test, PPIs would be first line. So omeprazole, lansoprazole, anything like that.
Apologies, sorry, we've got the wrong slide there. Bear with me, sorry, I've just accidentally got an answer there. Sorry about that. I'm sure a few of you already saw that answer there. Let's go on to question 8. So I'll set the timer for this as well, so you all have a minute. Okay, so hopefully you should all be familiar with this presentation by now. So we'll quickly go through it. So a 17-year-old female, so already you're thinking someone a bit younger, presents to the emergency department with peri-umbilical pain. So buzzword there, so pain around the umbilical region. The pain is sharp in nature, exacerbated by coughing, and came on gradually over the past 12 hours. So relatively acute onset. On examination, she's unable to stand on one leg comfortably and experiences pain on hip extension. So we'll discuss what sign that is shortly. There's no rebound tenderness or guarding. Pregnancy test is negative and temperature is 37.7. So they have a mild fever and they're not pregnant. So we're not thinking it's a gynecological cause. Bloods reveal leukocytosis, that's predominantly neutrophils. Which investigation is most sensitive in making a diagnosis? So the answer here was CT abdomen, abdomen and pelvis. So from the presentation, we're thinking that it's possible appendicitis. So thinking about the age of the patient. So usually if a young patient comes into the surgical clerking unit or STEC, surgical emergency care unit, and they're a bit younger, the first thing you think is appendicitis. And so they have the pain around the umbilical region. It doesn't have the classic radiation to the right iliac fossa because in younger patients, it's not always the case. So they might just be behaving slightly abnormally or just have this umbilical pain. Or it's just too acute an onset for it to have radiated by this point. And with an appendicitis, classically in the past, people would suggest doing an ultrasound abdomen, which you still see nowadays as well, but it's just not as sensitive. So if you're very suspicious clinically and it doesn't appear on the ultrasound, you then do a CT abdomen anyway. So often people just kind of skip that step and do a CT abdomen. So from an exam standpoint, it would be the right answer as well. So we'll quickly do another question. Similar in nature to this, so if everyone takes around a minute for this as well. Okay, so hopefully that's been enough time. So the answer here is Rovsing's sign. So Rovsing's sign is when you palpate in the left iliac fossa, it elicits pain in the right iliac fossa for the patient. Very simply, I'll just remember that as, if you remember the letter R, thinking about the right side. So if you palpate on the left, you get pain on the right. So R in Rovsing for that. McBurney's point we'll discuss, but it's more so the landmark or the anatomical location of the appendix. Psoas is when, if you extend the thigh, in the left lateral position, then it can cause right iliac fossa pain. And then you have your obturator sign, so you flex at the hip 90 degrees, flex at the knee 90 degrees, and then if you internally rotate the knee, then that also causes some pain for the patient as well. So very quickly, we'll whiz through this. So appendicitis is inflammation of the appendix. Etiology-wise, just remember the phrase poop rock, or if you want to be more medical, fecolith. And so there's some sort of obstruction into the stump of the appendix, which is then causing it to become inflamed. It's a surgical emergency. Anyone between the age of 10 to 20, start thinking about that as something you want to rule out because it is an emergency case. In terms of the symptoms, abdominal pain, classically you have periumbilical radiating to the right iliac fossa. Patients are often quite nauseous and might have vomited. They often have a low-grade fever as well, so you can see that from the stem of the question there as well. So that's the highlighted parts that are relevant. In terms of the signs, we've already discussed them, the top three. If they're a bit more peritonitic, so there's a risk that it may have perforated as well. So in that case, if you do reband tenderness, they're really guarding, they're really quite tender. You're thinking there might also be a possible perforation, which is definitely an emergency, more so an emergency. And McBurney's sign we touched on earlier. So it's the anatomical location. So remember, it's a third of the distance from the aces to the umbilicus. So remember that as well from an exams standpoint. You don't ever really mention that phrase clinically, though. It's just for your exams. Managing patients, because it's an emergency, likelihood is they will need to go to theatre for an emergency appendectomy. So try to keep them nil by mouth. If it's the next day, then nil by mouth in the evening or early morning at around 2 a.m. Fluids if they're in possible shock. Patients are often started on antibiotics, especially if you know surgery is going to be delayed by a day, for example. And then a laparoscopic appendectomy is the procedure that you would do. Some patients, it might not be appropriate to do surgery there and then, so you can treat them with antibiotics and they can have an appendectomy a bit further down the line, but it really depends on how the patient is clinically. Complications, as I mentioned, you can rupture or perforate, and that can cause peritonitis, and therefore the signs of peritonism, which we touched on, like the guarding, rebound tenderness. And it can cause a possible local collection as well. And so in that situation, you'd have to contact interventional radiology. They would do some sort of ultrasound guidance to think about draining the abscess. Question 10. So again, 1 minute on the board. Okay, so answer here is diverticulosis. So we'll quickly read through the stem together. So it's a 65-year-old gentleman, slight on the older side. We wouldn't say they're necessarily geriatric or anything, but anyone in that sort of age range, and they have rectal bleeding or PR bleed, then it's cancer until proven otherwise. But you can kind of elicit that from the history. So we'll have a look at what the stem says. So there's blood in the stool for the past few days. So it's more of an acute bleed, but yeah. He denies any fever, chills, nausea and vomiting, says that the bleeding is painless. So that's important. So it's a painless bleed. And there's not really any other remarkable symptoms. Last colonoscopy was 5 years ago, but only showed some diverticular, but no polyps or cancer. Temperature is 37, so they're afebrile. They're not tachycardic. Respiratory rate is normal, so less than 20. Blood pressure is also very normal. Rectal examination does not report any abnormality. What is the diagnosis? So there isn't anything for cancer in this stem. But if they just have a painless bleed and you know they have a history of diverticular, then most likely diagnosis is diverticulosis. There wasn't anything in the stem regarding, flaw symptoms like weight loss, etc., for cancer, but fortunately there wasn't anything in the answers for that. That would be cancer, so that would have been quite mean if there was. Let's quickly have a look at diverticular disease. The reason I put that question in is the definition is crucial from an examination standpoint. Just in general, when you're on the wards in general surgery as well, it will be very helpful because they're always using the different buzzwords. Thinking about etiology, so again, quite important to know for your exams. So remember, in the large bowel, you have your tinea coli. So these run longitudinally along the colon. So they present with these sorts of bands, and in between them, you have the mucosa. And so it's in between the tinea coli, you have the herniation. Sorry, not the herniation, the outpouchings developing. Just remember, if someone presents with left-sided abdominal pain and a PR bleed, then you're definitely thinking more so diverticulitis, or diverticular disease. And if there is pain, it's symptomatic, then you're thinking diverticular disease, as opposed to diverticulosis, which is just the presence of the diverticular. Because in the Western world, it's more so left-sided, so the descending colon and sigmoid. Remember, you don't find diverticular in the rectum. Interestingly, you can find it in the small bowel as well for some patients, but that's another thing. In terms of the risk factors, it's always good to ask the patients, have you had chronic constipation in the past? They often describe some sort of history of that, but it is often just age-related. The older you are, the more likely you are to have diverticular disease. Diverticulosis, patients are asymptomatic. They might just have blood in the stool, so a PR bleed. So in that case, the top two differentials are just going to be colorectal cancer or diverticulosis, or presence of diverticular. Diverticulitis is when you have when you're more symptomatic for it. So you have abdominal pain. Like I said, in the Western world, it's more likely to be left iliac fossa. If it's right iliac fossa, don't rule out diverticular disease because it might just be an abnormal presentation for the Western world or people from other parts of the world. They often have a fever because there's some sort of infection, inflammation. They're often tachycardic, and they might be distended. The abdomen might be distended, but not always the case. So in the stem, we basically rule out any features suggestive of diverticulitis. So it's more likely to be diverticulosis. In terms of the investigation, do your bloods. The main thing you're looking out for inflammatory infection markers. If they're raised, then it's more so diverticulitis, and the management is very different for that. I've written barium enema, but it's not necessarily seen as much. As with anything in Gen Surg, any issues, any sort of possible changes, patient might be deteriorating, CT abdomen them. From an exam standpoint, they'd often be happy with that. It's just the imaging of choice for most things now, abdomen related. And the colonoscopy a bit further down the line. So it's just important to note, if there is an acute inflammation or infection, you would not do a colonoscopy acutely, because if you put the camera up whilst there is active inflammation, there's a great risk of perforation. So often what you see is, if it is diverticulitis, so inflammation or infection of the diverticula, then you manage that acutely. You might then send the patients home on a shorter course of antibiotics to finish their course. And then you book in a colonoscopy a few weeks down the line just to make sure that inflammation is settled. So you wouldn't do that acutely, but it's definitely worth doing, especially if it's new disease, and also to rule out a possible cancer. Especially CT when there's active inflammation, the CT might say something along the lines of fat stranding, something like that. And it might show a possible mass, but you can confuse that for inflammation. So colonoscopy will kind of help because it checks for a mass, and also just to confirm the outpouching or the diverticular presence. In terms of managing it, just remember you can't reverse the growth, but you just prevent progression. So you prevent worsening of things. So it's largely lifestyle management. So there's a lot of advice. You give patients leaflets. So that includes fiber advice, etc. Make sure that they're well hydrated. So you're just trying to reduce the risk of constipation. Regarding the diet, you also often advise patients to have less seeds, those sorts of things that won't be digested, but they can get lodged in the diverticula and then can cause blockage, obstruction, and then inflammation or infection thereafter. And yeah, weight reduction, all of these things reduce intra-abdominal pressure, which reduce the risk of further outpatchings developing. If it's uncomplicated diverticulitis, so there's definitely an infection because you have raised inflammatory markers and whatnot, but the patient is otherwise clinically stable. It's often just a case of giving them some oral antibiotics, and you can even discharge them on that. If it's more complicated, definitely a bit more symptomatic, very tender and whatnot, then yeah, you do the other conservative management, like giving them fluids, analgesia, just depending on what clinical presentation is in front of you. If there is a collection, sometimes you see like a little perforation, and after a perforation, you can get like a little collection form around it. In that case, you might then refer to interventional radiology, and they can consider draining the abscess as well, again, guiding via the ultrasound. Remember with analgesia, so this is really important, don't try to avoid anything that's stimulant, so things like your Movicol. So try to give things more like Laxido, which isn't going to stimulate your bowel, rather it's just going to absorb water into the stool to soften it. And then avoid opioids ideally, because that can make people more constipated. So really try your best to work up the WHO ladder for pain. So start with paracetamol, then you can go to codeine, dihydrocodeine, and then go to slightly stronger opioids like oral morphine, IV morphine. Complications wise, yeah, you can get an abscess there, perforation. If it perforates, then some of the content goes into the abdomen, then you can get peritonitis. So that's important. All right, moving on to the next question. So again, 1 minute on the board. All right, so that's the minute up. So the answer here is acute pancreatitis. So let's quickly discuss this one. So it's a 53-year-old gentleman presenting to ED. So they have severe mid-epigastric abdominal pain that radiates through to the back. The pain improves when the patient leans forward and assumes the fetal position, but it worsens when they inspire deeply. He also complains of nausea, vomiting, and anorexia, gives a history of heavy alcohol intake. So the answer here was acute pancreatitis. So let me just quickly discuss that. Anytime anyone has epigastric, so upper abdominal pain, don't rule out the thorax. So think about the thoracic differential. So your heart attacks, there could be a pulmonary embolism, because it could just be on the border, or a slightly abnormal presentation. And then think about the abdominal stuff as well. So that can be your acute pancreatitis around there. It could be the biliary tree, as Nandini discussed earlier. But there's other things that are more pathognomic for acute pancreatitis here. So pain improving when they lean forward, is you do see that sign clinically. It's worse on deep inspiration. So when patients have that, you might be thinking pleuritic chest pain, like pulmonary embolism, which is completely valid to think. But just remember, when you breathe deeply, it's basically compressing on this inflamed pancreas, which is also why you get that sort of pain that resembles pleuritic chest pain. They complain of nausea and vomiting, very, very common. Often patients vomit a lot with this. And they have a heavy alcoholic intake. So you're thinking risk factors already for acute pancreatitis here, and a possible underlying cause. Tachycardic, tachypneic, febrile, with hypotension. So this patient is possibly quite unstable. They're agitated and confused. They have a temperature as well. They're tachycardic, and they appear quite pale, extremely tender. So often they are very tender when you palpate them. And here's another thing that's quite pathognomic for acute pancreatitis. So the amylase and lipase are raised. So from your standpoint, even mine, at F1 level, there's not many other things you consider when amylase and lipase are raised. So as soon as you see that in a stem, just automatically think acute pancreatitis. So very quickly, so inflammation of the pancreas, but remember this, if it's acute, because you can have chronic pancreatitis, but if it's acute and you resolve it well, then it can kind of settle and the damage can be reversed. If it's not resolved well, then it can become more chronic once there's permanent damage. Etiology, so you have the inflammation in the pancreas, it releases various minerals. The main one, that's calcium, it calcifies the pancreas. You get the breakdown of cells, and then you basically get this auto-digestion. So the cells break down, they release all the enzymes that the pancreas produces, and those enzymes then go on to digest the pancreas itself. And yeah, that obviously damages local structures and whatnot, and that's what causes the inflammation and the pain. Causes, I get smashed. So you'll use this in exams, and you'll use this on the wards as well. So when you clerk someone who you're thinking has acute pancreatitis, you're literally going through this point by point just to think of the underlying cause, because with quite a few of these things, as we go on to the management, you'll see that you have to treat the pancreatitis, which is often just more like symptomatic management and fluid management, but then actually get into the underlying cause so this doesn't happen again. Key ones you need to think about, it can just happen. So it can be idiopathic, but that's obviously once you've ruled out all the other things, there's a diagnosis of exclusion that. So check gallstones, that's the big one. Alcohol use is the big one. Trauma, that's the big one. So it's quite nice that those are actually separated in terms of the mnemonic, because those are the three you're thinking about. Think about their medication. So it could be steroids, a possible infection. It can be autoimmune. So you can do a pancreatitis screen, which I won't go into with much depth, but you can send off a screen on that front. And scorpion venom, just don't even say that on the wards. Like, yeah, your consultant will think you're an idiot. Hypercalcemia, hyperlipidemia. But sorry, from an exam standpoint, it's still worth knowing, because they might say, oh, they went to Amazon rainforest or something. Hypercalcemia, hyperlipidemia, this is really good. So on the blood test, check the calcium, check their lipid levels. ERCP, so that's actually an intervention, so therapeutic intervention. But the possible complication is that it can damage the pancreas as well. So I've seen this a couple of times where the patients come in a couple of weeks ago for ERCP, and then they start developing this epigastric pain. And so they've developed acute pancreatitis secondary to ERCP. And then certain drugs as well. So you check their medications. So the big ones you need to think about. So valproate, steroids, which we've already mentioned, etc. Pain, severe epigastric pain. It can radiate through to the back. When it radiates through to the back, you're also thinking it could be abdominal aneurysm. So think about that as well. Pain improves when they're sitting forward. Nausea and vomiting, fever, possibly. They'll describe some history of the cause. So if it's gallstones, they might describe a biliary colic picture. So they have pain that comes and goes in the right upper quadrant region. Alcohol, obviously, they'll tell you they drink lots of alcohol. Well, in a lot of cases, they don't tell you that, but you can refer to like substance misuse, and they're often a bit better at really getting to the bottom of that alcohol history. And they might be hypovolemic if they're more unstable. So 2 signs from an exam standpoint, you don't really see this clinically, but just remember Gray Turner sign. So I remember turning around the side. So that's the bruising on the flank or the sides. And then Cullen sign, that's a periumbilical bruising. Investigations wise, so amylase, lipase, they're very specific. Lipase is more specific than amylase. So if you have a choice of sending bloods off, ideally do the lipase, but do both. Ultrasound, not as sensitive. So CT abdomen, like I said, abdominal stuff, just think that. And that's quite good at showing the pancreas. Just so you're aware, I won't go into it in much depth, But the pancreas, if you look at it on a normal CT, is just quite fluffy, nicely rounded off somewhat. But when you have acute pancreatitis and you have the inflammation, that fluffiness, it all just kind of becomes like one color. So you can look into CT scans yourself. And then you're thinking about the cause as well. So if you're thinking it could be your gallstones, you can do ultrasound to check for the gallstones. If that doesn't show, you can then do an MRCP that also is more sensitive for gallstones. But like I said, calcium levels, lipid levels as well. Check that if you're trying to find the underlying cause. From an exam standpoint, this is really good. The modified Glasgow score. And based on this, you can determine like the severity of the pancreatitis. But ultimately, the management is very similar, irrespective of the severity. The only thing you need to think about, if it's very severe, so the patient's really unstable, then you're thinking they could go to HDU for closer like fluid management and whatnot there. In terms of the management, so from an exam standpoint, just remember manage the patient and what symptoms they come in with. So they're going to be in a lot of pain, give them the analgesia. With pancreatitis, you have quite a lot of inflammation going on in the body. With that, you can get a lot of third spacing of the fluid, so they go into the extravascular compartments. And because of that, you're going to be intravascularly depleted. So the blood in your vessels, that's why they're more likely to become hypovolemic. So basically, when a patient comes in, you start pumping them with fluid. So give them some stat fluids, give them over an hour, then over 2 hours. But again, it really depends on the patient. But for your standpoint, just pump them with loads of fluids. That's basically going to be the mainstay of your treatment, trying to treat them conservatively and dealing with their symptoms, and then dealing with the cause after that. So if you know that they have gallstones, so if you've suspected it and then you do an ultrasound, and if that doesn't show it, you do an MRCP, so an MRI, which looks more closely at the biliary tree. If that has shown gallstones, then you would do an ELCP down the line, which can resolve that. So one of the complications is that you can develop pancreatic necrosis. So if the patient's inflammatory markers really go up, they're really, really unwell, and you do another CT scan, the CT scan can show necrosis as well. So that's one thing to think about. And one solution to that might be necrosectomy. So they literally debride and get rid of all the necrosis. And in those patients, you often give antibiotics. So remember, although it is inflammation of the pancreas, it's not an infection. So with patients, you do not typically start them on antibiotics. You only start them on antibiotics if it's necrotic, and and necrosis doesn't necessarily always mean infection either. But if it's necrotic and you think that there's an infection there, then you start those patients on antibiotics. So acute pancreatitis, don't automatically think antibiotics. It's more so just pain, fluids, and then dealing with the underlying cause. And so that also includes substance misuse. So if you think it's because of an alcohol history, involve the substance misuse team and then try and wean them off alcohol, all of that stuff. For your exams, complications-wise, there's a few you need to know, just some buzzwords, but I won't go into much depth, like pseudocysts. So you can develop cysts after pancreatitis. If not managed correctly, or in some cases it is still managed, but you can still develop chronic pancreatitis. You're at more risk if you've experienced acute pancreatitis. Another one that's really important to know, which I've seen on the clinic on the wards a couple of times, is they can develop acute respiratory distress syndrome. So if a patient has acute pancreatitis, they will already kind of describe this pain where their breathing is limited, because when they breathe too deeply, the lungs compress onto the pancreas. But sometimes patients, they might actually start like desaturating, become really tachypneic. So don't just think, oh, it's because the pancreas or the lung function is limited because of the inflammation. It could be that they're actually developing a respiratory distress syndrome, which is obviously more severe, and then HDU usually get involved there. So remember, there's most patients, or a lot of the patients, their breathing will be limited somewhat. That doesn't necessarily mean they actually have lung injury, but that can develop if the pancreatitis is more severe. And because they become intravascularly depleted, you get all this third spacing of the fluid. Obviously, less fluids in the blood or the vessels, and so you can get AKI usually because of hypovolemia. Again, that's why fluids are so important. Okay, so this is it's more of a double question, but it's related to the same stem. So I'll give you a little bit longer for this one if you all have a read through. All right, so that's been around a minute. Okay, so we'll quickly go through the answers. So answer here is an inguinal hernia and then referring them routinely for surgical repair. So let's quickly look at the stem. 58-year-old patient. So again, with a hernia, they're usually a bit older. It's very unlikely for someone younger unless there's some serious pathology for them to develop a hernia. So they have no other past medical history. They have a right-sided lump in the groin. So immediately think hernia when you see that. Been present for around a couple of weeks, but it disappears when he lies down. So it's reducible clearly. And the swelling is reducible and not causing any pain. So they're not really symptomatic from it. It's just there and present. So 2 to 3 centimeter lump in the right groin, superior medial to the pubic tubercle. So that's really important for the location. So that's basically what gives you the answer of inguinal hernia. So if it's superior medial, so a bit higher, a bit closer to the middle than the pubic tubercle, then immediately think inguinal hernia. And we'll look at femoral hernia shortly. In terms of the appropriate management, here you can just refer them routinely because it's reducible, it's not causing any pain. So it's very unlikely for something more complicated to have happened here. But you do want to repair it a bit further down the line, especially if this patient is otherwise well. They are suitable for surgery, so they haven't got like loads of comorbidities. So you want to repair it down the line with a mesh repair. So you put a mesh there, reduces or prevents it from reoccurring, and that way that prevents more serious complications that can develop from a hernia, which we'll touch on shortly. Very quickly, the definition. So you have protrusion of abdominal content through the abdominal wall through an area of weakness. The two main ones you need to know about: inguinal, which is way more common, and femoral. And if you forget, it's just more likely to be an inguinal hernia, so you can always kind of assume that. Causes is due to increase in intra-abdominal pressure. So people who've done like boxing or weightlifting in their past, they're more likely to develop it. Chronic coughers, anything that causes you to like tense your abdomen is more likely to cause a hernia. If you have a look there, the main thing you need to think about that is a serious complication is an obstruction, because if the bowel content also goes through into the hernial sac, then it doesn't always happen. If there is bowel content, it doesn't always cause an obstruction, but it can. So if the patient isn't able to pass any farting, any poo, they have really distended stomach, and they have this hernia which is causing them a lot of pain, then alarm bells should be ringing. All right, so they've got obstruction and possibly incarcerated hernia. So if the blood supply is cut off, is strangulated, and that can cause incarceration. All right, so as I said, inguinal is superior-medial, so a bit higher up, closer to the middle is inguinal hernia, and it's above the pubic tubercle, so you should be able to palpate that on yourselves and on patients. If it's below that line, a bit more lateral, then think femoral hernia. But remember, it could also be something like a hydrocele, which I won't go into now, but look into differentiating hydroceles with like femoral and inguinal hernias. I think it's really important. But I won't go into that now. It's about trying to get above and beyond the the protrusion. All right, so the inguinal hernia, for the sake of time, I won't go into much depth, but we're going to upload our slides onto Medal so you can have a look at that then. And it's to do with the canals. From an exam standpoint, I would learn this. Clinical standpoint, you don't really need to know this too much, other than if you actually go into the theatre to do it. Remember, inguinal hernia is a buzzword, is Hasselbalch's triangle. You often find it in between these anatomical landmarks. So it's the lateral border of the rectus abdominis. It's just below the epigastric vessels and above the inguinal ligaments, in that sort of triangle. All right, femoral hernias, through the femoral canal. I'll leave that for now. Symptoms, patient often asymptomatic. They'll have a hernia, they'll go to their GP. GP will say, look, you're fine. You can just kind of tolerate this, and we'll then refer you to the general surgery team. They can put you on for the elective list for a mesh repair if you'd like. So often patients might be waiting for that, and then some complication happens if they then need an emergency surgery like incarceration or bowel obstruction. So they might have the hernia for some time. Some might not even notice it. It's more prominent when patients cough. So if there's a query hernia, I ask the patient to stand up. I do my examination straight away by them standing up, because it's just easier for you to see. And whilst they're standing as well, get them to cough. And the other thing you always want to do, can you reduce it? So check if it's a hernia, get them to cough. Can you reduce it? As soon as you can't reduce it, then already alarm bells are going, then you want to involve your seniors. All right. And that it won't cause pain unless it's a bit more serious, like incarcerated or strangulated. So as soon as there's pain with it, then again, think that is probably more serious. Managing it, so trying to prevent them doing things that are strenuous that would increase the intra-abdominal pressure. So that includes like losing weight, trying to limit how much lifting they do. If some complicated, you do an elective mesh repair, so a bit further down the line. It's often done laparoscopically. If it's a bit more serious, like you have an obstruction or there's a strangulation, you often do a laparotomy for that, because it's not just resolving the issue. You need to kind of, you need to look at things a bit more closely. And we discussed the complications already. All right. So question 13, again, a 2-part question. So I'll give you a bit of time to quickly go over this. All right, so that's been a minute. So the answer here is an anal fissure. Management-wise, we'll discuss that shortly, but that's the answer. Topical GTN cream, and then advising management, lifestyle approaches to the management. So the patient comes in, they have quite severe pain in the anal region. They have fresh red blood on the stool. So as soon as it's fresh red blood, you're thinking anatomy slightly closer to the anus. So that's like the descending colon, rectum, or the anus. If it's a bit darker in blood, it's a bit further, it's a bit more proximal than that, and often upper GI in nature. So yeah, if it's really painful, fresh red blood, just immediately think anal fissure. And the other key thing, sorry, no, it's not written here. He only opens his bowels once a week since he was young. So it implies chronic constipation. So often when patients are quite constipated, as you're like really straining, it increases the risk of a tear happening, and therefore anal fissure. Anal fissure, you have some sort of split in the mucosal lining. and you get pain on defecation. So there's a very close association between trying to pass stool and then this pain being exacerbated. Remember, chronic is if it's more than 6 weeks. Risk factors, so constipation, having hard stools, pregnancy is a big one as well because you have a lot of intra-abdominal pressure. Anything related to constipation, so opiates as well, cause you to be constipated. You get this fresh red blood. Patients often describe it as like passing glass, because if you think about it, every time you strain, you pass stool, it causes contraction, and therefore it literally spreads that anal fissure every time. So it just literally tears and tears. Hence why conservative management, like softening their stools, all of that is really important, so that they don't have to strain as much, and that prevents it worsening and also helps healing of the fissure. And you get this fresh red blood on the toilet paper. If you see fresh red blood, you're also thinking hemorrhoids, which we'll touch on shortly. It's a clinical diagnosis, so you're not going to do any sort of crazy investigations. Just remember, don't even ask the patient to do a PR exam. Don't write that down as one of the answers in the exam, and never ever do that on the ward, just to save you time, because even if you suggest it, the patient will tell you to go away because they won't be able to tolerate that at all. Management-wise, so conservative. So just think constipation is what's going to make things more difficult. So manage that. Give Laxido. So that will soften the stools by absorbing water into the stools, not anything that's stimulant, because that's just going to cause you to push hard stool through the fissure, which worsens things. The diet, so having more fiber, having more water in your diet, that also helps soften your stools. From a medical standpoint, you can give topical GTN. So it's a cream GTN, really good analgesia, and topical diltiazem as well. And that's been known to help. Most patients will heal in around 1 to 2 months. If not, then you can think about other things as well. So like botulinum toxin, that literally like relaxes the muscles. So obviously you can imagine that prevents it worsening and improves it. And then you can do sphincterectomy as well. So you literally do a cut into the sphincter, and that again opens things up. So there's less strain when you're pushing through, which helps with healing. Question 14. So again, a minute on the board for this. Sorry, everyone. It's gone a little bit over. I appreciate you might all have to go away. If you do choose to go away and you quickly leave, I'd really, really appreciate if you could do the feedback form, which I'm not sure is on here, but we'll send that out to you after the session as well. All right, so the answer here is grade 2 hemorrhoids, so part E. So yeah, again, you have fresh red blood. As soon as you start suspecting like there's a mass coming out of the anus, then you're thinking more so hemorrhoids. Or it could obviously be an anal cancer as well. But in this case, it's the mass comes out and it spontaneously resolves. So it's going out and then back in. And that's what you need to know for the grading, right? Whether it spontaneously reduces or whether the patient needs to manually reduce, but we'll touch on that shortly. And again, yeah, so there's fresh red blood on the paper. So again, always think hemorrhoids and anal fissure. And the key differentiation is pain versus no pain. There is a type of hemorrhoid which can be painful as well, which we'll discuss now too. So buzzword is the pectinate line or the dentate line. So that's this line that separates the superior portion of the anal rectum and then the inferior portion. And the hemorrhoids can develop above or below. So they can be internal hemorrhoids or external hemorrhoids, depending on whether they're above or below that dentate line. That's more so academic, and that they can definitely ask that in the exam. Grading is really important. There's no prolapse at all. There's just these prominent vessels and only bleeding. So this you can only really say from when you do an investigation, which we'll discuss. Grade 2, the mass comes out, so the hemorrhoids come up, they spontaneously reduce. If the patient has to physically or like manually reduce it themselves, then that's grade 3. Grade 4, they're just not able to reduce at all. Just loads of the content has come out. And that's for internal hemorrhoids, just to be aware. So yeah, we've already discussed the PET presentation, so continue. In terms of the investigation you do, an anoscopic examination, you put a scope up, that allows you to visualize things more closely. And that confirms the diagnosis, but often you can just say it's hemorrhoids from the clinical examination, but you always do this just to kind of see the staging as well. Manage them conservatively often. So again, constipation advised, discourage straining because that can worsen the hemorrhoids. But often, based on the severity, there are different approaches as well. You can use steroids. So steroids can kind of shrink the hemorrhoids, but it's not completely curative. The thing that is very curative is a rubber band ligation. So they literally put this rubber band around the hemorrhoid, and then over several days to weeks, that cuts off the blood supply to the hemorrhoid, and it kind of just necroses, falls off, and then you excrete it, and that's the hemorrhoid dealt with. And it can reoccur, but with a lot of patients, it just deals with things. And you can also do surgical hemorrhoidectomy if it's completely non-reducible. And yeah, so that's more of a theatre or surgical approach. So yeah, rubber band ligation you can do as an outpatient, whereas the other one is in theatres. All right. So the hemorrhoids can become thrombosed. So if there's reduced blood supply going through, they become thrombosed. They become really painful, and they do become very purplish. So you can often see that from a clinical standpoint. And this is more of an emergency. You kind of want to bring patients in. You might have to think about a surgical approach for this. Question 15. So again, minute on the board for this. All right, so that's been around a minute. So the answer here is IBS. So it's a young lady. So if they're young and they're female, already start thinking about IBS once they have tummy pain. It's mainly lower abdominal pain. It's a bit crampy, but it goes away after she opens her bowels. There's a bit of association with passing stool. She says that she goes to the loo to pass stool a number of times per day, and it can be watery, so there's a bit of diarrhea. Diet consists of burgers, pizza, and pasta, so relatively unhealthy. Everything else is normal. Examination, all the bloods and whatnot. So likely diagnosis, once everything else is really excluded, young female, think IBS. Here, it's not going to be the other things. Gastroenteritis, you'd have raised inflammatory markers. UC you'd see some other stuff, but we'll differentiate with celiac now. So whenever you see IBS, the thing to differentiate is celiac, because you have similar demographic, but we'll discuss why this is also IBS. It's not going to be celiac because, again, serology is all negative. So you would have sent off like a celiac screen, hopefully, and that comes back negative. All right. IBS versus celiac. So very similar presenting complaints. They're bloated. They have abnormal passing stool, so it can be diarrhea. They have this tummy pain. Just know IBS is a bit lower down in the abdominal region, whereas celiac is general, but that's not 100% true for everyone. IBS, different foods can make it worse, but in celiac, it's specifically things that have gluten in it. So for either patient, you ask them to keep a food diary. It's really important. So defecation can help with pain in IBS, but there's no correlation in celiacs because you just always have that constant inflammation. Examination-wise, they're normal in IBS. Celiac, one thing you classically see is dermatitis herpetiformis. So this is sort of like a scaly rash, which we'll look at. Remember, in IBS, you have to rule everything else out before you can say it's IBS. You can't just say, from a clinical standpoint, I think it's this. And then celiac, you do some blood tests, including IgA, TTG, and endoscopy can also show some results. IBS, you get this recurrent abdominal pain. The pathophysiology isn't very well understood. Some people suspect it might just be possibly like psychological, or can just be idiopathic in people as well. Risk factors, anything that might have caused psychological trauma in the past. Other abdominal conditions in their past medical history. But remember, it's more common in females than it is in males. And it's usually younger patients. Defecation helps with pain often, but again, not strictly true for everyone. But from an examination standpoint, that's something that they might throw in, and the examination is normal. Remember, exclude everything else. The things you're thinking, especially because it's often a younger patient, think about celiacs, think about IBD, so the test for that. And then it could possibly be a colorectal cancer, so you send off the screen for that as well. So that includes the FIT test rather than the FOB test. Advise them lifestyle things. So there's things that they can do to reduce the risk of it happening. So avoiding there might be some sort of trigger, hence why food diary is really important. So you can ask them to avoid those triggers. Fiber often helps. Trying to manage like the psychological side of things helps as well. So often when people are more stressed, they're more likely to get IBS symptoms, like when people revise for exams. I had a few friends who just always develop IBS. Educating patients, that's really important. Medical standpoint, there's a few things you can do, but it's not as commonly done. Celiac disease, so this is an autoimmune condition, and you basically get autoimmune response to when you eat gluten, and specifically a molecule called gliadin in the gluten. From a microscopic standpoint, you get this villus atrophy, hypertrophy in the intestinal crypts. Literally just memorize that, because you're going to need to know that for celiac disease. They love asking questions on the pathophysiology for it, and those are the two lines. So villus atrophy, hypertrophy, intestinal crypts, which remember it's gliadin, is the specific molecule in gluten. Risk factors, family history of it is big. If they're IgA deficient, the association with other autoimmune conditions, including type 1 diabetes or thyroid conditions, and again, more common in females. We've already discussed the presentation. The key one here that I wanted to highlight is dermatitis herpetiformis. So often you'll see that on the elbows, it's like this scaly patch on the extensors. You can also get it on the face, the neck, the scalp as well. In terms of the investigations, classic send-off for IgA TTG. You can do endomysial antibody as well. So those are the two classic bloods you send off. And then when you do an endoscopy, so they can have a closer look at the bowels, this is where you see those signs of villus atrophy and crypt hyperplasia. And often they take a biopsy as well. Gluten-free diet, nice and easy. That's how you would manage them. But you can also give vitamin and mineral supplements as well. Refer to a specialist, because there's really good specialist centers for that. Question 16. So we're coming up to the last couple of questions. So not much longer left now. So again, a minute on the board for this one. All right, so that's the minute done. So the answer here is part D. All right, so we'll have a look at this one together. So 35-year-old, they're obese, they're a female, so they have a history of gallstones. So remember your 4Fs, so female, fat, 40, and fertile. So those are the risk factors for people having gallstones in the first place. In this case, we already know they have a known history of gallstones. They present to the ED. They have this right upper quadrant pain for around 16 hours. Sorry, everyone. If you just bear with me, let me just quickly turn my lights on just to make sure you can all. All right. We'll get back to it. So, yeah, they have this right upper quadrant pain for the last 16 hours. Vomiting, they're very nauseous. They have a temperature of 39.8, so very febrile. Murphy sign is positive. So we've already touched on this. Nandini's basically gone through this. I'll very, very quickly skim through just to add to it. But in this case, so this patient, very tender right upper quadrant. So you definitely want to have some sort of analgesia in there, which is why options D and E are automatically the ones to go for. A has oral paracetamol, but that's not really going to get the job done for quite severe abdominal pain. So also just go straight to D and E. Patient can be put down on the hot cholecystectomy or to have the cholecystectomy within 7 days. But the reason I haven't said option B is the best one because you're not thinking about the analgesia side of things there. But that is definitely a valid option as well. And again, there's no antibiotics there. You do want to start these patients on antibiotics. Part C, the ERCP, you do that if there's actual obstruction of one of the ducts, which there isn't necessarily here. So cholecystitis doesn't mean there's an obstruction of the ducts. That is acute cholangitis. Cholecystitis is just inflammation of the gallbladder. It doesn't necessarily mean there's an obstruction of the ducts. So you wouldn't need to do an ERCP. Here, you give them fluids. Okay, so they obviously have an infection. You want to give them fluids. They're nil by mouth. Sorry, they're vomiting. So they're going to be fluid depleted. So give them fluids. So that's resolved that. Intramuscular diclofenac, so an NSAID. That's quite good at dealing with abdominal pain. And again, because they can't swallow, they're vomiting, they might not be able to keep anything down. So it's good to think about IM or IV alternatives, giving them IV fluids and antibiotics. And the other thing you would then want to do is to think about doing a cholecystectomy within 7 days. So in a lot of centers, you need to find out when the symptoms started. If it is eventually confirmed to be cholecystitis from the scan, you need to find out when it is, because if it is within the 7-day window, you can do a cholecystectomy there and then. Anything after 7 days, because of all the inflammation and infection that's been there, you can get this kind of fibrosis around the gallbladder, and that basically makes the anatomy very difficult for the surgeon to deal with. And if you're not confident, there's a very high risk of you nicking one of the bile ducts or one of the ducts in there, and that is a whole nother complication. You have to send them to like a specialist hepatobiliary center, loads of niche procedures that would then need to be done. So you don't want to do anything risky. It's actually quite a difficult operation, even though they're very common. But yes, so the main reason it's not option B is because you're not thinking about the other things like fluids, pain management. All right, so very quickly, if there is or are gallstones in the gallbladder, cholelithiasis is the word. So again, similar to diverticular disease, learn all the different definitions here. It will be very, very important. If you have the presence of gallstones, plus it's actually causing the pain, so you get colicky pain, so pain comes and it goes, and it's often associated with eating fatty foods. So if someone comes in with this right upper quadrant pain, they say the pain comes and goes, first thing I ask is, does it often come on after you've eaten like a fatty meal? Or when was the last time you ate a fatty meal? Because they're more likely to describe some sort of association with that. If they have presence of gallstones, so cholelithiasis, plus they have inflammation / an infection, then it's acute cholecystitis. So that's when you get inflammation and infection of it. Remember, you don't get jaundice with this. You get jaundice if there's acute cholangitis, because that is when you have an obstruction in the ducts, in the biliary ducts. And that's what causes jaundice. But just inflammation of the gallbladder does not cause jaundice, but it does cause pain, it does cause inflammation / infection. The investigation of choice, you do an ultrasound. The ultrasound can show you if it's got cholecystitis, and it shows the presence of gallstones. But again, it's not as accurate as an MRCP. So an MRCP will show you the gallstones a lot better, but also a CT abdomen is very good as well at showing the cholecystitis. So if you kind of do a stepwise investigation, so you can do a CT abdomen if you're suspecting cholecystitis, but that won't show you the gallstones. So you can then also do an ultrasound on top to confirm that there are gallstones in there. And then if the gallstones don't show anything, but you're still sure there's probably stones in there, then you do an MRCP. All right, so that's really important. If you're not suspicious that it's cholecystitis, so there's an inflammation or infection, you just think it's biliary colic, so there's pain that comes and goes, then you don't need to worry about a CT abdomen. That's just to see the cholecystitis. You can then, all you need to think about is there gallstones, so then you do the ultrasound. If that doesn't show, you do the MRCP. All right, so that'll be important, really important for your exams, but really, really important clinically if you remember that. So yeah, management-wise, if it's just presence of gallstones, it's just an incidental finding, which is weird because you wouldn't do like an ultrasound there or an MRCP unless you're suspicious of that. But that would just be an incidental finding, so you don't need to manage it. If the patient actually describes colicky pain that comes and goes, those gallstones are misbehaving, they're going in and out of the neck of that gallbladder, then to make sure there's no complications down the line and also to relieve the patient's symptoms, you just do a cholecystectomy down the line, so an elective cholecystectomy. If they have acute inflammation, you can do a cholecystectomy within a week. Obviously, if they're not really unwell, they're not like septic or anything. Otherwise, you wait for the inflammation to settle, and again, you just do it down the line. But in the acute phase, you need to give analgesia, fluids if they need, if they're like vomiting, and antibiotics. All right. So that's the minimum, but then you might do a surgery there and then. If not, you wait a bit further down the line electively. If there's a gallstone in the common bile duct, that's now called choledocholithiasis. Okay, so another annoying word there. But yeah, if you then have that, plus you have an infection, that's now ascending cholangitis. All right. And ERCP is the procedure of choice to resolve that. Again, you do the same thing. So ultrasound, see if there is a stone there. If that doesn't show it, then you do the MRCP. And then, so those are your investigations. And then ERCP is an intervention. So then that would be the next step if you have seen ascending cholangitis there, and there is a clear obstruction. Remember, you're also looking at the bloods as well. So in an obstructive picture, you see ALP and gamma GT are raised, and also bilirubin is raised. So if you also see those on the bloods, then yeah, you're sure that there's some sort of biliary tree obstruction. Management, yeah, we've already discussed. With ascending cholangitis, you can do an ERCP, but again, the baseline, giving them fluids, giving them pain relief, and IV antibiotics. And ascending cholangitis, if you see that in a patient, it's very severe. So you definitely need to keep them in, really monitor them, give them IV antibiotics, because that's a lot scarier than cholecystitis. Really nice table, summarizes everything, and differentiates the four conditions. You can take a screenshot of this, but again, slides would also be up. All right. And that's it. So that rounds off the presentation. Before you all leave, I would really, really appreciate one thing. If you all just quickly post your emails, whoever's left here in the chat, I'd really appreciate it, just because we haven't actually put the feedback slides on Medal. We've forgotten this week. But that way I can email you a feedback form, and I'd really, really appreciate it. It'll take you like 30 seconds to a minute to fill out. Helps me a lot for applications and whatnot down the line. So I'll wait a little bit. If you guys could just quickly post your emails, if you're still there, that is. Lovely. Thank you, Callum. Anyone else? Anyone still awake? Beverly as well. Perfect. I hope that was useful. Sorry for taking so long as well, but quite a few important pointers there that I wanted to highlight, which is why it took a bit longer. Lovely. Thanks so much, everyone. I think that's most people. Cool. Thanks so much, everyone. I'll send you an email out for the feedback, so I'd really appreciate that. You're very welcome, Ting. All right. All the best, everyone. Good luck.